My name is Aamir Khan, and I'm going to talk to you about a dream that I have of using cell phones to improve healthcare delivery in Pakistan. We all tend to meet all kinds of people on the streets of Pakistan. Here's a gentleman that I met while I was working in Rawalpindi. And what struck me was this level of self-confidence that he had, this statement that, here I stand to be counted. I wish I could say that about our society. I wish I could say that about the way we deliver healthcare to our people. Over the last 17 years, I've been working to improve public health. And every time I've started to do anything, I've always come across the same challenge. How do we figure out how many people there are at risk, how many people there are that have the disease, and how many people there are that might be on treatment? So I met this man while I was working with the London School of Hygiene and Tropical Medicine to map sex workers and injecting drug users across 12 cities in Pakistan. The purpose was for us to be able to target interventions that might slow the spread of HIV in these specific communities. We use a social mapping approach, a social mapping method, to figure out where these hotspots were, where sex workers and injecting drug users operated. And we had a team of health workers that would walk through ordinary mohallas, like the one pictured on the upper left picture there. And they would walk through these mohallas and they'd talk to people about whether or not they could help identify local hotspots where some of this high-risk activity was taking place. But more interestingly, what we did was we used cell phones or smartphones that we provided to these health workers in rugged covers, in common files, so that we could protect the device and also protect them from theft while these people were walking out in the community late at night interviewing all of these people. What we had running on those phones, on those devices, was software that we had designed that allowed us to ensure data entry error checks, to make sure that we could tell when an interview took place, how long the interview was. And then we could also capture GPS coordinates. So where did that interview take place? What we did with that information at the end of the day, or sometimes early AM in the morning because these health workers were interviewing sex workers late at night, this data would be emailed back to Karachi from across these cities, and it would then help us generate maps like this. So this is just a Google image of Rawalpindi, and this is an example of a map that we use to monitor our field teams. The example here that you might want to focus in on is the red box. So the red box is the red team, and on day 5, on D5 at 6:30 p.m., they did a interview at that hotspot. And we were able to monitor many teams working across all of these cities simultaneously without really needing very close field supervision in the place. And that's very attractive when you're trying to do this work at this scale. That's something that the GPS on that cell phone allowed us to do. We were then also able to take that data, and on this map I show you the data collected on the cell phone, and plot it on another map of Rawalpindi, which now shows you the kinds of findings that came about from this study. So here, in green, are hotspots. These are locations where sex workers operate in and around Murray Road in Rawalpindi. In blue are unique IDs that we just identified to keep these sites anonymous otherwise while sharing with the government. In white are the ranges of the estimates of the range of the number of sex workers operating at that particular spot. And what you see up here in pink, the 103 to 127, is actually a mohalla with 6 or 7 koti khanas that may be well known to some here, perhaps, in the audience as well. Now, we didn't come to that point without our trials and tribulations. My group's been working with the Johns Hopkins Bloomberg School of Public Health in Pakistan over the last decade, trying to figure out how much pneumonia we have and how great a burden it is on our children. And we're doing this to figure out which might be the best vaccines to introduce in countries like Pakistan. So we've established, over the last decade, 3 sites, one in the Karakorums and 2 in Karachi. And I'm going to share with you the experience from the first site a decade ago in the northern areas. And I want you to look at this image going from the top left clockwise. So we were working just north of Gilgit city in what's Ghizar district, in the Punyal and Nishkaman valleys. These are high mountain Himalayan populations. typically ranging from 6,000 to even 10,500 feet. We worked with government lady health workers, and here's a picture of one standing outside her home with the notice board. And we used them to enroll 5,200 children from birth to 36 months of age to 3 years of age, and we followed those children every 2 weeks at home using over 100 of these lady health workers. The houses, these health houses of these lady health workers were plotted here in green, and some government hospitals and private clinics can be seen in red. So we use very rudimentary GPS location devices to sort of map out what altitude this pneumonia cases might have been taking place. But the whole exercise was really taxing because we collected over 170,000 forms. And even though they were scannable forms, those forms had to be edited in the field, in remote locations, and then brought back to Gilgit for scanning and data entry to take place. And we knew after the amount of money, heartache, and pain that we spent and suffered, that we would never do it that way again, that we'd have to figure out a better, faster, less expensive way of doing this. And we focused in on electronic medical records and accessing those with mobile phone devices. So this is our current site. We're working in Kurangi, in Karachi city. We have 2.6 million people that we serve who are mapped out to the household level. These 2.6 million people are from every major ethnic and religious group in Pakistan. We work with the Indus Hospital based in that community. And what we've done over the last 4 years is send survey teams door to door, paint individual numbers on these otherwise unplanned communities, and give a unique ID to every household in that area. We then take those maps and digitize them onto Google Earth so that we are finally able to get street maps for the communities that we serve. Maps that let our health workers get back to the patients that we've seen at the hospital, maps that provide us a research sampling frame, and ways of figuring out how we can actually deliver healthcare in this community. What we then did was take all of that data and created Google layers. And what you can finally visualize from those maps was, well, here are examples of clinics, GP clinics in red, government EPI centers or vaccination centers in light blue, hospitals in H, and then children, the cases that we were seeing of pneumonia across this site. And we could sort of visualize them by the information that we had on them. But this was very static information. So my team then designed a system called interactive alerts. And the best way to describe this system is to show you the video.
We're about to show you a real-world implementation of interactive alerts being used in Karachi, Pakistan to track patients in a pneumonia surveillance study for a 2-year period. We'll be using RFID tags in the form of a bracelet like this and a Nokia 6131 NFC phone that has a RFID reader and writer embedded in it. At the data management unit, IDs are assigned from the server to RFID tags that will later be issued to patients in the form of bracelets. In Pakistan, culturally, the bracelet is very acceptable. We can assign IDs of different types. For this demo, we'll use test patients. Tags can also be reissued to patients in the case of damage or theft, while our system can disable the older tag and keep track of the current active tag for that patient. We are now at an EPI center where our field worker enrolls patients. After the parent has consented to participate in the study, the field worker scans a bracelet to activate the tag and ties it on the child's wrist. This change in tag status is posted to our server and can be viewed in real time. The field worker now collects further information about the child to complete enrollment. All patient data will now be linked to the patient ID on the tag. Now suppose the child is ill and visits a surveillance GP clinic. We have placed the same Nokia phone in a housing on the GP's desk. The child comes in, the GP examines the child, scans the tag, and enters the diagnosis. This diagnosis is sent to our server in real time using GPRS, which generates an alert SMS आ गया to the mobile team, which consists of the surveillance medical officer and a phlebotomist waiting to respond to events occurring with our study subjects. The mobile team has now received the SMS. They know the time the child came in, where the child is located, and what was diagnosed by the GP, so they can respond to the event immediately. The mobile team has now responded. The surveillance medical officer examines the child and documents the event. In some cases, the phlebotomist may need a blood sample. After drawing blood, the phlebotomist scans the tag and enters the culture tube ID on the Nokia phone. The blood sample is now also linked with the patient ID on the RFID tag. The same is done for all lab results and X-rays. All field data is available online. For example, we can get a quick summary of all patient encounters by entering the patient ID. Under the GP tag, we can see the diagnosis, the GP's location, and so forth. With interactive alerts, we can monitor events in the field as they happen, and it gives teams the ability to respond immediately to emergencies. This system links all patient data from enrollment to lab results in real time.
Interactive alerts, which we built in partnership with the Media Lab at MIT and the D Lab at MIT and our team here in Karachi, but which was coded and tested by our teams in Karachi, won a global award, the WEMA 2009 award for near-field communication technologies. And we have been very happy with this, were it not for what happened next. Interactive alerts was entered into a Smithsonian design competition and actually got accepted and is now on exhibit at the Smithsonian Museum of Design in New York, and you can see it till January 2011. Pakistani technology that actually gets to a place like that. And we have been happy with this, were it not for what we've just learned last week. We've been invited, my colleague Sarah Khwaja and I, to present this system and some of our other systems to the first ladies that are meeting at the UN Summit in New York in September. And we intend to make it a point to demonstrate the kinds of success that come out of a country like Pakistan. So I don't want to walk away giving you a sense that we've just had a success after success after success. We've been in this business for 10 years. We've been trying to figure out how to collect data better, how to get information back to people that need to make decisions cheaply. But every problem, of course, generates a new problem. And one of the problems that our system, Interactive Alerts, generated was an overload of data. We had so many data points and so many tables to go through that program managers found it difficult to figure out what to decide. So we next had to work to extend that software to convert data to information. And we did this by linking the data coming from the cell phone in real time, and this is important, in real time from these government and private health facilities back to the server, being processed, visualized on Google Earth. So what you're now looking at is data coming from some of those centers. This is actually Sindh Government Hospital, Kurangi, where you can see the total number of child visits that took place that day. You can look at the number of vaccinations that were administered to children at a particular site and look back at its history in terms of how many vaccinations have been given at that site over the course of the last few months. We then decided that we wanted to take this further, and we started working with our partner, Indus Hospital, which provides quality care free of cost and is actually Pakistan's first paperless hospital. And because it was paperless, we figured if we could connect their electronic medical record in that building and then attach the cell phone to that system, we could extend Indus Hospital services outside of the building to the community at large, those 2.6 million people that we were describing earlier. Working with Harvard Medical School and OpenX Data Consortium, we built this system called OpenMRS Mobile for tuberculosis, for our tuberculosis program. You've seen some of this. It lets us collect GPS coordinates and information on whether patients have taken TB drugs on any given day. I call this the TB horizon. When you look outside in this hospital, in one direction, these are our TB patients currently on treatment, mapped back to their home. So you have a sense of how much TB there is in your community. Well, we wanted to do more. So the next thing that we did was we linked the medical records at Indus hospitals to the information that was coming from the cell phone and from home. And so a program manager could click on one of those patients and open up the patient's medical record right there on the Google Earth interface. So you would be able to pick up programmatic data from the field, and electronic medical records from the hospital, bring it together for somebody to make an informed decision. All made on open source software that's going to be available later this year for download by other people as well, inshallah. So our message for the planning commissions and the governments and the bureaucrats of Pakistan, there's this pervasive technology that's become part of our life, and we can use it. Here's a demonstration of what you might be able to do by taking a cell phone down to each health center, collecting data on individual patients, aggregating it at the city level, at the province level, at the national level. And this is what it might look like for Punjab if it made that move, for TB at least. I want to end with my acknowledgement to the genius of the cell phone, its designers, the people that create the software on it, and what it allows people like me to dream up and do in countries like Pakistan. I also want to acknowledge, of course, our partners, all of those who've supported and funded our work here in Pakistan, who've brought their intelligence to being on this as well, and individually, these very young, talented Pakistanis and our collaborators around the world that have built these systems to do what we now are able to do, at least in some parts of Pakistan. Thank you very much.